Good afternoon, everybody. Welcome back to this session today, an engagement hearing for Fit for the Future here in Gloucester. So just to give people a quick update of what's happened so far today, we had a morning session in which we heard a written submission from Suicide Crisis and had a brief discussion about it. And then we heard from Councillor Richard Stanley of Tewkesbury Borough Council with a very constructive conversation exploring his views on things that needs to be considered as part of the Fit for the Future programme. We've just taken a nice break. For the benefit of those of you who are joining us for the afternoon who weren't here this morning, we're just going to do reintroductions basically of our panel who are here to listen to submissions, and I'll give a brief explanation of how that works so everybody's aware of it before I invite Councillor Clucas to come up and talk to us. So my name's Nick Duffin. I'm the chair today, independent chair. I'm from the Consultation Institute, of which I'm a fellow. On my left, Jeremy.
My name is Jeremy Welch. I'm a GP in Tewkesbury and I work for the Clinical Commissioning Group as part of the Urgent Care team.
Hi, I'm Amjad Uppal. I'm a General Adult Psychiatrist and Medical Director in the Gloucester Health and Care NHS Foundation Trust.
Afternoon, I'm Simon Lansley. I'm Director of Strategy at Gloucestershire Hospitals.
Hello, my name is Julie Clatworthy and I'm the independent nurse on the governing body of the CCG.
Good afternoon, my name is Mark Pietroni. I'm the Medical Director and Director for Safety at Gloucestershire Hospitals NHS Foundation Trust, and I'm also a consultant acute physician.
Okay. Rob?
Good afternoon, I'm Rob Stacey. I'm an emergency medicine consultant working at both Cheltenham and Gloucester Hospitals.
Good afternoon, I'm Eve Olivan. I'm the Divisional Director for Quality and Nursing for Medicine at Gloucestershire Hospitals, and I'm also the Specialty Director for Cardiology and Respiratory Services.
Hello, my name is Catherine Campbell. I'm the Service Director for Urgent Care in Gloucester Health and Care NHS Foundation Trust.
Hello, my name is Maria Metherall and I'm the Senior Nurse within Gloucestershire Clinical Commissioning Group for Urgent and Emergency Care.
Okay, so for those of you who didn't take part in the morning session, the format is relatively straightforward. We have 5 different people, organisations who are coming to present to us this afternoon, starting off with the Councillor Flo Clucas. Professor Robert Arnott of Cheltenham Labour Party will follow, then Tony Foster of a Cheltenham resident, the organisation REACH, and John Thurston of the Friends of Lydney Hospital will be talking to us. So that's the agenda for the afternoon. Each person or organisation talking to us has effectively a 45-minute space in which they can say whatever they want to, essentially speaking. The role of the panel is to listen. The role of the panel is to hear what people have to say, but also to explore what people have to say with a view to helping contribute towards solutions for the different forms of care needed for the communities of Gloucestershire as part of Fit for the Future programme. So it just gives you a quick oversight. So without further ado, and to move things along, Councillor Clucas, would you like to come and talk to us? Have we got a mic? Yeah. Okay. Thank you for coming in today. So the floor is all yours.
Oh, right, okay. Firstly, can I ask you to excuse my voice? I've not been so good for the last couple of weeks, but I thought this was far too important to miss.
Okay.
The thrust of what I'm going to say is in relation to local care, accident and emergency, and the issue in relation to staff numbers. Okay? Now, I have to say immediately, I am not a medic. I am not in the health service. I am not a doctor in any sense of the medical term. I'm here to represent my constituents, the people of Cheltenham, and those members of the council from cross-party who have the same concerns as I do, and indeed as other colleagues do. So it may well be that some of the questions that you pose I will not be in a position to answer, but I say that immediately. We heard the Secretary of State say yesterday that he had spoken to the Chief Executive of the Hospitals Trust, and she had confirmed what would be an extremely significant decision that the Accident and Emergency Department at Cheltenham would not close. He said that on the floor of the House of Commons yesterday, and very grateful I was to hear it. Until I realised that actually the A&E department at Cheltenham had never been down for closure, ever. What was down for consideration was a significant downgrading of that department. And as you will all be aware, there are 4 separate categories of accident and emergency department. Those are Type 1, which is an accident and emergency department, which is consultant-led, 24-hour service with full resuscitation facilities and designed accommodation for the reception of accident and emergency patients. There's Type 2, which is a consultant-led, single speciality, accident and emergency service, for example, ophthalmology or dental, with designated accommodation for the reception of patients. We then move to Type 3 and 4. Type 3 and 4 are urgent care centres, but they're also classified as accident and emergency departments. And those urgent care centres are a different kind of accident and emergency department in that they deal with minor injuries, with the designation of the reception of accident and emergency patients, but without the facilities that a Type 1 base would have. And that's extremely important because anybody can classify that kind of department as an accident and emergency department. The fact is, it is not a Type 1 accident and emergency department, which is what the people of Cheltenham and indeed Tewkesbury, and my understanding is certainly a significant number in Gloucester, actually wish to have retained in both places. Therefore, I think that the Secretary of State's statement, which was made in the House of Commons yesterday, was significant, but it lacked proper definition. And that's where I look to you, all of you, to set that proper definition. Because without the proper definition of the Accident and Emergency Department, then frankly, we're not getting anywhere. Let me say immediately that my constituents want a fully functioning Type 1 accident and emergency department at Cheltenham, and there are reasons why they do. Those reasons I will come into in a little while, but I want to begin by looking at the consultation process. I don't know how many of you have children, do you? Okay, I have 2 boys, 2 sons, and one of my sons, the younger of the 2, became absolutely obsessed by magic. He loved watching magicians on television and decided at the age of 9 he wanted to be a magician. And so, heaven help us, for the next 20 years, what we had was the opportunity to watch him practice his table magic, which meant that he could convince us that he was doing one thing when actually he was doing something else. Sleight of hand, a very ingenious way for magicians to behave. I believe that the Fit for the Future questionnaire is precisely that. It is sleight of hand. And the reason I say that is because it is designed to lead the reader to a particular conclusion, not to give hard and fast facts and ask the reader to make up their own mind, but it is the reader is led, the contributor is led to a particular conclusion. Let me give you some examples. One of the issues outlined in that questionnaire is that only something like 1 in 3 patients who turn up at A&E actually need an A&E department. What is not said is that some 70% actually do need an A&E department. And of course, until you go to an A&E department, you don't know, and the doctor doesn't know, whether you need accident and emergency treatment. So I think that that's part of what is being done through that consultation process. So what we're looking at is a mechanism which is designed to take the reader, take the contributor, to the conclusion that what we need is not 2 accident and emergency departments in Gloucester and Cheltenham, but actually that we need one centre of excellence and 2 urgent treatment centres. That is not what my constituents want, and I have to keep repeating that, because if I didn't, then I'm not sure that you would hear. So we know that accident and emergency departments are staffed differently from urgent treatment centres. And one of the issues that brings to the fore is not just the issue of local treatment, but those areas and organisations and people outside of the county that depend on treatment, for example, in Cheltenham. I'm thinking of the oncology area. I'm thinking of those from Hereford and Worcester who come to Cheltenham for treatment and who, without general surgeons available 24 hours a day, could be put seriously at risk. And that is my fear and my belief if we don't have a type 1 A&E. So let's look now at some of the UTC, the Urgent Treatment Centre provision that is outlined. We were told at the Council's Overview and Scrutiny Committee, and indeed I think it was repeated at the County's Health Scrutiny Committee, that patients would be able to access the Urgent Treatment Centre by contacting their own doctor. They would be able to phone their doctor and arrange to go into a UTC at Cheltenham by appointment. Well, let me say to you that there is one example that I'm going to give you where that has happened recently. A gentleman, around about 8 o'clock in the evening, in severe pain. He phoned 101. 101 said he should go to Cirencester. This gentleman lives in Cheltenham. He should go to Cirencester to be seen by a GP because everywhere else was closed. He went to Cirencester. He was seen by the GP at 10 o'clock, or approaching 10 o'clock. The GP immediately referred him to Gloucester A&E. He went to Gloucester A&E, so from Cheltenham to Cirencester to Gloucester. In Gloucester A&E, he was seen by a medic, a senior doctor. That senior doctor put him in a bed, in a cubicle, to await results of tests. He was there for some 3 hours. At the end of that time, they told him they didn't have a bed for him, and therefore he would have to go home until the early morning, which he did, and he was then to go directly to Cheltenham A&E. That was what he did, and he was admitted to Cheltenham Hospital. So this gentleman, following the procedure that is being suggested in this, went around the county to come back to his local hospital for A&E assessment and then into a hospital bed. You surely cannot be suggesting that for all those people who live outside of Gloucester as a mechanism for ensuring proper treatment. You surely cannot be suggesting that. If you are, then I would like to see your reasons why. Because what happens in Cheltenham is not just a Cheltenham issue. It affects the entire county. It affects those who go to Gloucester A&E and the numbers, and having seen the numbers piled up there myself, I know how often that happens. It also affects those who are seeking a bed in hospital, and having seen the numbers of bed shortages there have been in Gloucester, I know that happens. And it strikes me that what we're looking at here is a mechanism that is designed to push people away from accident and emergency without attacking the real problem. And I'll tell you what the real problem is. The real problem here is we do not have enough medical staff in the county to do the job that they need to do. We don't have enough GPs. We don't have enough district nurses. We don't have enough nurses in hospital. We don't have enough technicians. And that's the real issue. And to try and utilise a change in accident and emergency to counter that, I think, is wrong. So, my constituents. I'm concerned at a number of comments that have been made. The first concern I have is that we have been told that what we're going through now is an engagement process, and that will then lead to proposals coming forward, and those proposals, when they come forward, will be put to the public in relation to consultation. But we have also been told, and I've taken this from the minutes of the meeting, the Chief Executive has told both the O&S Committee and I understand the HOS Committee that although no decisions had been made, the public doesn't decide the future of services, it is the trust which decides. If that is the case, where on earth does that leave this engagement? Where on earth does that leave the consultation process that is going to happen? Because what that says to us is, well, actually, you can say what you like, but really, we'll look at that and then, no, we'll go and do our own thing. That's how it comes across to the public. Whether that's intended or not is immaterial. That is what comes across to the public, and that is what you need to face, because this hearing is here to make sure the voice of the public is heard. And if that is actually the case, then for goodness sake, be honest about it and stop all the faffing around with consultations and hearings. I also want to thank the Chief Executive of the Trust, because she also said in those meetings this week, indeed at Tewkesbury Council, that it was best to deliver local care. She's quite right, but that local care has to be good, appropriate local care, and that local care has to reflect the needs of the people, because those people who require that expect nothing less. And that is not simply an urgent treatment centre at Cheltenham Hospital. If you listen to what is said across the county and the tens of thousands of people who have signed petitions and made their views known, you will know that the people across the county do not want Cheltenham to use its Type 1 A&E department. It wants it back, it wants it there, it wants it permanently, not simply to quieten things down while other stuff happens. And so if we're looking now at that situation, I want to say this on behalf of my constituents. These are our hospitals. They belong to us, they belong to the people. The people pay for them through the public purse, as we pay for staff. And the Trust should listen to the people, because the people know what their needs are. This is not just a question of we want, it's a question of we need. And I was a little disconcerted to read in one of the documents that there was a comment made, whether it was accurate or not, I do not know, but I'll state it here. And that comment was, well, yes, we know that there are plans for lots of homes, but homes don't mean people. Because Cheltenham, Gloucester, Tewkesbury, the whole county is going to increase in population. In Cheltenham alone, just one area, west of Cheltenham, there are going to be 7,000 jobs created in the new cyber centre. There are going to be 3,000 homes just in that one area. That's not to mention Swindon Village, which is going to have another 4 and a bit thousand. We are seeing a huge drive to increase population, a huge drive to increase the economic vitality of the county, and only last night we had that from both the county and the local enterprise partnership about how they want this to be a success and how they are pushing to make that happen. If that's the case, then downgrading or closing an accident and emergency department at Cheltenham, and I understand that it will be an A&E, which is an urgent treatment centre if these proposals go ahead. But it's not an accident and emergency department, and that is going to affect all of those people who come here, all of those people who want to come here, all of those children who grow up here, because what we're going to have is a paucity of service, and that's not good enough. So I would ask you to listen to what the people of Cheltenham and the people of the county are saying to you. This is not about, we've got to have an emergency department because we've got to have one. This is about real concern and the real concern of ordinary people. We need 2 fully functioning A&E departments to serve Gloucestershire, especially given the population growth that I've just outlined. Not one supposed centre of excellence, which will not do the job that is required. The second thing that needs to happen is we need to concentrate on getting more of the staff at local level that can do the job through GP surgeries, and we're not doing that at the moment. The final thing I wish to do is to ask a list of questions. I understand you may not be able to answer them now, but I would wish to answer them. The first question is, I would like to know what exact reassurance was given to the Secretary of State for Health by the local NHS Trust. That is pertinent to all of these discussions. The second is, was the Secretary of State given reassurance that a consultant-led service throughout the day will remain at Cheltenham General Hospital? If yes, then for how long? My third question, are local NHS managers proposing to include, as part of next year's consultation, the option for the retention of a consultant-led A&E department at Cheltenham General Hospital? My fourth question, will the option of removing A&E consultants from Cheltenham General Hospital during the day feature as part of the consultation? And that begs the question also about care for oncology and other patients who would require a GI surgeon to be present to ensure that any emergencies could be properly met while they stay in hospital. Number 5, does the local hospitals trust and the clinical commissioning group agree that the best outcome is for a consultant-led A&E department to remain at Cheltenham General Hospital? And my final question, in the opinion of the local NHS Trust and CCG, if the option of removing the consultant-led service at Cheltenham General Hospital is not being pursued, do the pressures that led to this outcome being discussed still exist? Thank you for your attention.
Okay. Thank you very much, Councillor. With regards to those questions, as you rightly surmised, is that not all of them could be answered by the panel members. But if we can have a copy of the questions, then you'll get a written response to them.
Thank you.
Some of those questions are with regards to the model of care, and my understanding is, and I don't know if anybody would differentiate from it, is that as they are in an earlier stage of the process and not yet at consultation or deciding what will be consulted upon, some of those models are yet to be decided, and this is part of a process that will influence what those models will look like, essentially. So, but in the meantime, I mean, are you happy for the panel to explore with you some of the issues and the topics that you've raised?
Indeed, but I would ask you to remember I am not a medic.
No, of course. Okay. But you might have some ideas that are good.
Indeed.
Yeah. Anybody got anything to ask? Kathy? Yeah.
Hello, Flo. My name's Kathy. I lead the urgent care teams within the community, and I'm interested in what you think your views of your constituents are about care closer to the home, closer than even the A&E, so that we treat patients or people, we treat our population before escalation starts with their healthcare needs. Have you had much feedback about what your constituents want closer to their actual home rather than looking at our buildings and what we provide there?
Yes, we have, and that feedback has been that one of the problems that we have, and I think this is pertinent to the discussion, is that in order to get access to a GP appointment, it is virtually impossible. 2-3 weeks to wait? Well, if you are in pain, or if you have fears about a condition you have, or if you've had an accident, your first port of call is going to be A&E, because that's the only way you are going to get somebody who knows what is wrong with you to treat you. So I think there is an issue there. I also think there's an issue with things such as prescribing pharmacists. I think they need to be brought more into the fore, but I also think that we need to have a proper look at how our service across the whole of the county is operating. It cannot be right to say that somebody who is seriously ill or believes they are seriously ill because they are in pain, as that gentleman was, or have a particular problem. Indeed, I heard another one this week. Somebody went to the Tewkesbury UTC, was sent to Gloucester for treatment and had to be picked up from Gloucester. I mean, for goodness sake, that the accessibility issue, particularly for those who are least able to afford taxis and runabouts, is incredible. And yet nowhere in here do I see that. So I would actually say to you, yes, I understand that. But firstly, without the staff, it ain't going to work. Secondly, without considering accessibility for A&E, which has become a port of call for people who can't get to see a doctor, then it ain't going to work. So what needs to happen, for me, is we need to look at how we're staffing things, how we're doing things, And where we need to retain services and build around them, A&E for me is a classic.
Jerry?
Jeremy Welch, I'm a GP in Tewkesbury. I was just going to pick up on the GP appointments. You quoted sort of 3 to 4 weeks sometimes for appointments.
2 to 3.
And I think those figures, I would see those figures as for a routine appointment. So I know I'll speak for my surgery at the moment. I know if you rang up my surgery, the wait is about 2 weeks for a routine appointment. I know that every patient who rings on the day is asked by my reception team, is this urgent for today? Would you like to speak to a doctor or see a doctor on the day? And they will be spoken to or seen on that very day. So I just wanted to clarify the difference between an urgent on the day appointment versus a routine appointment.
Yeah, I'm happy to respond to that, because one of the problems that we have, and I think it's the issue you've asked about is pertinent to that, is that when you say to somebody, well, you know, are you seriously in pain? Do you really need to see a doctor today? They'll think, oh God, no, it's fine, honestly, I can wait. That's the sort of response that you will get. And what happens then is that 2, 3, 5 days later, while they're waiting for their routine appointment, things will get so serious for them, they will go to A&E. And I think that's a big issue. And I think that's particularly the case with older people who don't want to feel they're a bother to doctors. And in this county, we have perhaps a good many older people who would fall into that category. So while I appreciate what you say, and I understand about the routineness of appointments, yes, but actually getting patients to admit that they really do need, and indeed I think the issue in relation to telling patients be honest with your doctor is a really serious one, because they don't want to disturb or upset doctors, many of them.
I definitely accept that, and it is a challenge. And I would reflect back personally to my surgery that we actually took out of the script that our receptionist said about the word urgent. The conversation is now, were you looking for an appointment on the day, or were you looking for a routine appointment to see a doctor of your choice? And so we've had to sort of adapt and change that because of that very rationale that you explained, because I know I have very stoical patients who, oh no, I don't want on the day, I know you're under pressure. But then I also have patients who very much may escalate something that probably on reflection didn't need on the day, and I have to accept that some of those patients will be seen. I mean, at the moment in Gloucestershire, we know we're offering around 5,000 appointments on the day with our 74 GP surgeries across the county, and we are desperately looking to increase it. There is, as you touched on, increasing staffing. With the primary care networks, the new GP contract, there are additional staff coming on board. They're not here now. They will be coming over the next 5 years to help.
5 years?
Continuously over the next 5 years, yeah.
5 years. Yeah. And the reason I say that is not to denigrate what you say. Yep. It's actually to say 5 years. And that will not be the numbers of staff that we need, because, of course, we're going to have GPs who are going to be retiring. So I think there are real issues there. And while I accept what you say about on the day, the difficulty is that for many people, until they see a doctor, they don't know how seriously ill they are. And many people will downplay, oh no, I'm fine, you know, I won't go to it, no, I'll be okay, I'll wait to see how I am tomorrow. And that issue, I think, is a really serious one. And I accept what you say about the 5,000 appointments on the day, but there will be many people who will not know how seriously ill they are, sure, and therefore will wait and make the situation worse. And that's why an A&E department at Cheltenham is so necessary. A fully functioning Type 1 A&E department is so necessary.
Triage, as we would call it, speaking to patients to sort of expand and understand what's going on, is challenging. You touched on an example from the gentleman from Cheltenham who ended up in Cirencester, then Gloucester, then Cheltenham. Triage is difficult, and we would not claim to get it right every time. The idea of triage is that many patients, they almost want to test their symptoms, and they'll ring the surgery to test them, or they'll ring 111 to test them. The vast majority would get a good outcome. I absolutely accept the gentleman, the example, the anecdote you gave us. It didn't work out well for that gentleman. He got the right care eventually, but he had a bit of a runaround, didn't he? We speak to lots of patients as GPs, as nurse practitioners, paramedics every day, who actually triage is a benefit for them, and actually the use of 111 or the GP practice helps to make their journey better for them.
But the reason I cited that gentleman's case is simple. It's because had he been able to go to Cheltenham A&E, he'd have been seen, he'd have had a bed, he'd have been treated the next day, instead of which he had 24 hours of pain. That's not right. And, you know, a fully functioning A&E department at Cheltenham may well be in a position where it can do that for many more people if it is there, if it's retained, and if it's run properly. Now, as far as I'm concerned, that gentleman suffered unnecessarily, and I'm really angry about it, suffered unnecessarily because he was given the runaround. And I'm going to use that phrase. It should never have happened, okay? Shouldn't have happened. And I would not wish anybody else to go through that, but I have heard only in the last week or so of another case where a young mum was given precisely that runaround. It should not happen.
So are you advocating that we should see all patients every time?
What I'm advocating is that if, given the extent of the pain that that gentleman and the young mum was in, had they been able to go to Cheltenham A&E and see a specialist emergency medic, then that specialist emergency medic would A, have admitted one immediately, and B, would have prescribed the right medication for the person who was ultimately sent to Gloucester A&E. And I would also say to you that anyone who's been to Gloucester A&E, and we haven't even hit the winter issue yet, you will know how busy it is. You will know that there are people waiting in corridors because I've seen them myself. And you will also know that there is a significant bed shortage at the hospital. So how on earth is it going to cope with the extra pressure if Cheltenham A&E Type 1 closes? How? My way of thinking, it isn't, and I have yet to see any evidence that shows me it will.
Just one lot. I would welcome the opportunity, with permission of the patient you described, just to look at what happened in that journey with Maria to understand why that didn't work out, because it is a very well evidenced pathway and it clearly failed in that point, and we look to learn from those examples.
Well, I'm sure the gentleman concerned would be happy to speak to you should you wish to.
Okay. Yep, Maria?
One question?
Yeah.
Thank you very much. I think your Cheltenham to Cirencester to Gloucester Royal scenario is a very interesting one, and as Jeremy said, be very interested to look into that scenario. One of the things I've heard as I've gone around the county talking to people about how we deliver urgent care across Gloucestershire is that people find navigating themselves, signposting themselves around our system very, very confusing. And I think your scenario emphasises how confusing it may feel for patients. Yep. Have you got any thoughts or ideas or any feedback from your constituents around how we could help improve that confusion that we probably have created for patients trying to find their way to the right service? Because you're describing, we provide many services that support patients with an on-the-day urgent need, and you've talked about pharmacies, we've got our GP practices, we've got our out-of-hours services, we've got our minor injury and illness units, we've got a plethora of services, but trying to make sure we get your constituents to the right place first time is really, really important to me and us, and I wonder if you've got any thoughts or ideas on that.
Gosh, that's come left field. I think the first thing that needs to happen is there needs to be a clarity, because the patient was triaged through 101. That was the number that he was told to ring. That was the number he phoned. The triage took place. The triage resulted in him being sent to Cirencester. That is, what, 17 miles from his home? 18 miles? And when he got there, the GP, I think it's fair to say, was aghast at what happened to him and told him he should have gone directly to an A&E department. So I think that the first thing I would suggest is that people who are responsible on numbers such as 101 should actually understand that by sending people on that kind of round journey, they're not doing any favours for anybody. Now, there was a triage done there, and the fact that the person who did the triage understood that the person needed to see a doctor immediately, I think was significant. But what should then have happened was the person concerned, instead of being sent to Cirencester to see a GP, was sent to Gloucester. So there needs to be a greater level of training and understanding in relation to 101. I think if I was looking at improving the system, I would suggest that the interesting thing that is being proposed here is that GPs should be able to make appointments for patients by telephone in this supposed new system. I'm not sure that's going to work. And I'm not sure that's going to work, firstly, because I can't see, and I wouldn't ask my GP at 10 o'clock at night to phone a UTC or an A department and get me seen. I just wouldn't do it. All GPs, and I say this with respect to people here, are entitled to their home life and their family and children. So I wouldn't do it. And if I wouldn't do it, knowing what I know about the system, my bet is 90% of people wouldn't. So the first thing that needs to happen is you need to really review what's happening with 101 and how that is working. The second thing I think you need to look seriously at is the potential implications for the ambulance service. Because if you have people picked up by ambulance to be taken to an urgent treatment centre, then have to go by ambulance to an accident and emergency centre, then you're giving yourselves a real problem. And I don't see how what is being proposed in here is going to rectify that. So I would suggest that there needs to be better training for 101 staff. I think there needs to be better training for GP staff as well, and for those who answer the telephone to understand that you can't simply triage and send somebody 17 miles to see a GP if actually what they need is to be seen at A&E.
Thank you. Can I just pick up on your bookable point of getting appointments booked in urgent care services? I think just to put that in some context, we are certainly looking at making many of our urgent care services more bookable in order to make what are called urgent care more planned. Clearly, we're not expecting GPs at home to be booking appointments. What we are looking at, and we've already started work within our 111 service, booking appointments directly into our minor injury and illness units, which very much helps us to support managing the surge that we often see in our system. So the move to bookable is designed to be convenient to patients. So I'm just interested from your point of view about sort of how you foresee that. So actually you would ring 111, and if they felt you needed an appointment with your GP, an appointment would be booked for you. Does that resonate with something your constituents would like and appreciate?
That sounds really rather complex to me.
Okay.
I'm trying to think of it, not for myself, but for others. I think if somebody needs to see a doctor, what they don't want is to be going through a bureaucratic system. You phone your GP makes an appointment. Why? Why can't you just make an appointment yourself? Why can't you just do it? Okay. I think that's one issue. The second issue is we were told that this, the Overview and Scrutiny Committee, by one of the senior doctors who was there, that this is something that would be done, that you would be able to contact your doctor out of hours, your doctor would then phone and make an appointment for you, or contact your doctor and the doctor would make an appointment for you for the urgent treatment centre. The problem I see it, and this is what is not being addressed at all, is that for those people who feel they need urgent appointments, urgent care, then what that does is bat them away. And it does something else too. Actually, when you look at the figures presented in the Fit for the Future consultation document, what it said was 3 out of 10 people, between 25 and 33%, don't need urgent treatment. But the other 70% do, and they will not know until they've gone and been seen at an A&E department. They just won't know it, okay? So the idea that you can have somebody phone a GP, chat to a GP, and with the best will in the world, GPs aren't psychic. They can't see what they're not being told. And therefore, the idea that that is going to solve all our problems, I think, is frankly a fool's paradise. It will be fine for some, but for others it won't be.
Okay. Any other?
If I may.
Yep.
So I'm Rob Stacey, I'm an emergency medicine consultant working at both hospitals. So the majority of my time is spent clinical in an emergency department, and about A third of that is in Cheltenham, 2/3 is in Gloucester currently.
I'm going to stop you for a second because I'm deaf.
My apologies.
Thank you. No, you don't know because I didn't tell you. That's what I mean by doctors needing to be psychic, you see. So please carry on.
So you highlight some of the very issues that this process of engagement is trying to tackle. So you've talked about staffing, and within that not enough list, there are some key staffing groups that we struggle to recruit to, and despite efforts continue to struggle. So that's one problem for which we need to find a solution. You also talk about the difficulty of navigating our service. And that links into your concern about accident and emergency departments, because our accident and emergency departments are now catering for a mix of patients. They are not all patients who necessarily need to see an emergency medicine consultant. So how do we design a system that is easy to navigate and can care for the needs of that now mixed population? So that's the challenge of this. And the other thing I just wanted to really talk about is we mentioned about type 1 departments and defining them by the presence of an accident emergency medicine consultant. Many of my valued colleagues are from different backgrounds now. So when we discuss the role of a GP in the urgent care system, or me and my role in the urgent care system, I think we need to describe the role that specialist nurses play. So our expert nurses in our emergency departments and our minor injury and illness units, and how they can play a part in urgent and emergency care. But for those sickest patients, how can I make sure that a senior emergency department doctor is available? And how can I provide that service for the whole of Gloucestershire? And is that achievable on 2 sites? All of this comes also back to one of those other problems you've identified, which is the experience at Gloucester is of it being crowded. So I'm also looking for a solution where Gloucestershire Emergency Department is not that crowded experience. I will not be advocating for a solution where we just increase workload at Gloucestershire. I want to balance that workload so you can get an excellent service wherever you are in the county, whatever your urgent care need. So some of those problems are exactly those things we're trying to fix.
Well, can I just say thank you? I think that was a really valuable contribution. I would just make a couple of points. Firstly, you've concentrated on staffing, navigation, Gloucester and the difficulties there, and also the sickest. I think, if memory serves me right, in the papers it talks of the sickest 8% needing a centre of excellence in effect. Well, what about the other 92%? I accept that you're going to have some very seriously ill patients and that you will need to care for them. I accept that. But you're also going to have an awful lot of other people who need A&E, and you're not going to have that for them if you take Cheltenham away, because what you're going to do is pack Gloucester Royal. You're going to make it more difficult than it is now. 5 years before you begin to get to grips with the staffing issue. And that's 5 years where you're going to have that kind of problem and more, because you're going to have a population growth. So I think you have a real problem. The second issue I want to raise is in relation to the point you made about catering for a mix of patients. I think that's right, but ask, why are you catering for a mix of patients? The fact is, you're catering for a mix of patients because you haven't got the service elsewhere. And for that is not your fault as a doctor. That is the fault of the way the system has been done, the way the system has been created. We need district nurses. We need proper social care. We need a whole host of things which you are trying, or rather the document is trying to answer by taking out one fully functioning accident and emergency department and putting people off going to the other. It isn't going to happen. And I'm not going to risk the lives of my constituents by ignoring that as an issue. I just couldn't do it. And I want people to know and understand that is actually at the base of what is on offer here. And until you begin to get to grips with the issues in relation to staffing, retirements of medical staff, both nurses and doctors and others, the fact that some of our physios and some of our radiographers come from Eastern Europe, our ambulance staff, some of them were recruited deliberately from Eastern Europe because we couldn't get people to work in the service here. You have to come to terms with all of that, because what I see in relation to this is the simple answer to an extraordinarily complex problem, and the simple answer on this occasion isn't going to make that difference that it needs to make. And, you know, I say that in all sincerity and with all respect to all of you. Look at this from the patient's point of view. And if you do, what you see is confusion, what you see is a lack of information about what service you should be using and when. You see an issue in relation to, for example, how you access your GP if you really need urgent care. All of that is not existing, and so to do this now, before you have that, is wrong. You need to be thinking seriously about that.
You continue to raise valid points. There's just the one thing, or two things I pick up, if I may. I don't see this as a process of trying to discourage people from attending one department. And if it's a short way to answer some of your concerns, I imagine that the 20 plus years of my career as a notes medicine consultant, I'm going to continue to be working in Cheltenham. So it's perhaps just I'm not trying to design a system where I'm not working in Cheltenham. I anticipate I will continue to be working there, providing care in Cheltenham. But how we design the rest of the system around that is part of this process.
I understand that, but I would, for the sake of repetition, if you don't mind, just say to you that the people of Cheltenham want a Type 1 accident and emergency department retained. They understand that Gloucester cannot cope. And if a Type 1 accident and emergency department in Cheltenham is closed and replaced with an urgent care facility, you will find Gloucester not just swamped, but drowned in the numbers of people who go there. Okay? And I want to make that point because I understand what you've said, but it doesn't answer the basic question. And the basic question is, how do you sort it? Not close a department.
I'm conscious of time, so a final question.
Sorry.
Thank you, Councillor. I'd just like to pick up on some of the things you said at the end. You, I think, very accurately and passionately described some of the issues that we're facing, many of which are beyond Gloucestershire. And at the end, you went, you know, four square into the realm of politics and political decision-making, which is outside the remit of this group. But it does have an impact on the decisions that people around this table and in the organisations represented here do have to make. And it's, you know, let's be honest about it, resourcing matters. The only thing I would like to say is to reiterate perhaps a comment that Rob made. You know, and as a doctor myself who practices in both hospitals and both A&E departments as well, nobody around this table, and certainly none of us, is going to do anything that is going to put people's lives at risk. There's no way that any of us could support decision making that would put people's lives at risk. And you know, I give you that as my personal assurance as the medical director and as the director for safety of the trust. That doesn't mean that complex and difficult decisions don't have to be made, but I couldn't support a decision that I thought was putting people's lives at risk.
I would just make one comment on that, which actually doesn't concern Gloucestershire, but I think is pertinent. There was a report on television last night of a patient who waited 6 hours on a trolley at A&E in Coventry and died as a result. No member of staff in that hospital would have thought about that being an issue or a problem. No member of staff at that hospital would have wanted that to happen. But it happened. And it happened because of overcrowding in the A&E department. I would not be able to sit back and allow that to happen here without a fight. And that's why I'm here today. Because I do not believe that Gloucestershire Royal can actually cope with the numbers that are going to go. I don't think it can cope now with the numbers. And I think you need to take a very serious look at what's happening and why. And I accept exactly what you're saying about the politics, which is why I've been very clear that the people with whom I have been working has been on an all-party basis. Every single party in the council has taken the sorts of views that I have expressed to you. And I would say to you that if this means we have to go on and knock on government's door and get them to say, well, 50 million isn't enough, then that is what we should do, and we should do that as a family concerned with the welfare of the people of Gloucestershire and Herefordshire and Worcestershire who use our services. That is what I would say to you.
Okay. Councillor, I mean, we're going to have to finish there because obviously we've got the allotted times, and Professor Arnott will be waiting to come on and talk to us as well. But it's been a really enlightening and interesting conversation.
Thank you.
And some really important points for consideration that you've raised, many of which were already being discussed, of course, as you're aware. But the perspective that you've brought to it is very revealing and useful, I think, and it gives people a full feel for the feeling that is out there as well, that you're representing through your constituents.
If I can just say, I've left a copy of the questions there, and you asked about the gentleman who had been through that. Yeah. I think the Secretariat has my email address, so what I would suggest is if you want to email me, I will put you in touch with him, and you can actually have a chat to him. Okay?
Okay. Councillor, thank you very much again.
Indeed. Thank you for your time.
Thank you. Right, so we're going to talk with Professor Robert Arnott in just 1 second, but I think they're miking him up. So just while we're waiting, I don't know, just around the table, any further thoughts on what we've just heard, really?
I mean, I just add one comment that I think Flo picked up on, and obviously previously, is around the issue around staffing and resources, and absolutely accept the challenge for us. As Mark said, none of us would support a decision that didn't ensure patient safety, but we have the resource we have. So the challenge for us, I suppose, is how do we work more effectively with the public to design a service that accepts the resource limitations we have, but is meeting the needs of the local population. It's not an easy answer.
Yeah.
Yeah, just to add to that, so this is about developing a longer term vision, isn't it? So absolutely accept Flo's points. If we made some changes that are being talked about, if we made those changes now, absolutely both sides wouldn't be able to cope. So this is about saying what's the long term vision, and then we make operational decisions around capacity and workforce to deliver that. Yeah. So it isn't about making short term changes now.
And can I add that we mustn't forget what the community offer is. Yeah. We need to be looking, and we are, I know we are, we're working very collaboratively to look to see further upstream how we can support our population before they become unwell. Community services such as health and care are really striving forward with that, and I think we should firstly celebrate but then develop further what we're doing, because I think the opportunities are definitely there.